So we're going to be talking today about what we've learned from this little experiment that Georgia has been running for the last few years. We have been we are currently the only state with an active work and community engagement requirement for Medicaid enrollees. We're not the only state to have tried this. Arkansas tried this and it did not go well. But here in Georgia, we decided to try it again anyway. And so for the last few years, myself, many people here in the audience, and my panelists up here today have really been watching how this little experiment has played out. And now that H.R. 1 is going to bring, at the end of 2026, unless something changes, this requirement now to all the states that have fully expanded Medicaid under the ACA, we thought we would talk a little bit about what we could learn from Georgia and hopefully have y'all leave here with a few ideas for stories, because I know your editors are all going to say, why did I pay for you to go to this conference? So we'll end there. A little about, there we go. So I'm Sam Whitehead. I am one of the members of our Southern Bureau for KFF Health News based here in Atlanta. I've been a reporter here in Atlanta for about 10 years and was in the very room when the press kind of got pre-spun on this program before it was actually announced to the public, as I think some other people here were as well. I am joined today by Leah Chan. She is the Director of Health Justice at the Georgia Budget and Policy Institute. They are the think tank here in Georgia that has really led the way on kind of crunching the numbers and really making sure that the public and policymakers aren't kept in the dark about this program and its impacts on individuals and the state budget and the federal budget, importantly. And also by Deanna Williams. She's an enrollment assistant with Georgians for a Healthy Future. They're a consumer advocacy group based here in Georgia. Deanna is joining us from Middle Georgia, where she works directly to help people navigate the pipes of Georgia pathways to coverage. Very confusing pipes, we will learn today. And so maybe just to get us started and orient the conversation we're going to have, I'm going to just give y'all a little bit of a background on what this program is, and then we'll use that as kind of a jumping off point for how the new rules in H.R. 1 are slightly different and the implications of that, and then get into, again, some of the lessons we can learn. So despite being kind of passed by legislation in 2019, Georgia Pathways did not launch until July of 2023, in part because while the program was first approved by the Trump administration kind of in their final days, when the Biden administration came in, they said not so fast. That kicked off a long legal fight, which eventually the CMS just kind of stood down. They decided not to appeal it up to the 11th Circuit. My guess is because they thought they would lose. So eventually Pathways did launch in July of 2023. The kind of basics here, Georgia is one of 10 states that has not expanded Medicaid under the ACA. And that, I would say, from my reporter's perspective, in the 2018 campaign where Brian Kemp ran against Stacey Abrams, that was a real kind of cudgel that Abrams used in that campaign. It was kind of a political liability for a Republican governor to not have a health care thing. And so instead of full expansion, they thought, okay, well, let's try this thing that's kind of been tried out before and see how it goes. So enrollees must complete 80 hours of work or other qualifying activity a month to qualify for Georgia Pathways to coverage. The original idea was that the state would keep verifying whether or not people met that requirement. That has not been happening, and we'll get to some of those reasons why. And just kind of looking at where things are right now, and these numbers are a little backdated in part because, reporting is slow and it's sometimes hard to get the state to tell us what the numbers are. So as of, through March this year, so as of April 1, 100,000 Georgians had applied to the program. As of June, only 8,000 people were actively enrolled. What that says to me is people are interested in health coverage, right? people in the expansion expansion population in the coverage gap want coverage, but with a program like Georgia has run, obtaining that coverage is not always the simplest thing. And if you compare what Georgia has done to a full Medicaid expansion under the ACA, this estimate I think is from Robert Wood Johnson. They estimate about 300,000 people would gain Medicaid health coverage. And not only has this program maybe not been super efficient, it's also been pretty expensive. So as of, these numbers are maybe from a month ago, the state is, well, no, these are updated, we got the latest reports. So the state has spent over $100 million to run this program, or on the program in total. Only $26 million of that has been on benefits. Which I think just speaks really to how complex this program is for a state to run, I think any state to run, and really to the fact that because it is so complex, it is hard for people to actually make it into the program. And in Georgia, at least, where we do have a kind of single point of entry for our state benefits, the launch of pathways and the additional administrative burden it put on our state eligibility system actually slowed down how long it took people to get other benefits like food stamps and cash assistance, right? So when you have a system that has to take on this much administrative work, it doesn't just affect the people, say, applying for that one benefit program. It ripples out, right? Because there are only so many caseworkers, right? There are only so many people to answer questions when someone has a problem, regardless of which benefit that they're looking to use. And so now what I'd like to do is, if I can end this slideshow and open the other one, I'm going to pass things off to Leah here, who is going to talk to us a little bit about some of these great data that GBPI has kind of put together. So I guess, Leah, maybe before we get to some of the data, talk a little bit for us, if you could, about how the work rules coming in H.R. 1 differ from the program that we have here in Georgia.
Sure. Yeah. So when you compare what we have in Georgia to H.R. 1, what we have in Georgia is actually more restrictive. Largely, a lot of the qualifying activities are the same. So in order to qualify for pathways to coverage, you have to be an adult, 19 to 64, not eligible for traditional Medicaid, earning less than 100% of the federal poverty level as your household income. And you have to report currently on a monthly basis 80 hours of work, volunteering, higher education, or some other combination of qualifying activities, which could include, vocational rehab, some work programs, et cetera. We do not have any long-term exemptions. We have good cause exemptions, which are short-term, but that's one of the, I think, one of the big differences between H.R. 1 and pathways is that H.R. 1 does have some mandatory long-term exemptions. For example, fully disabled veterans, parents or caregivers of folks who have a disabled individual in the household, foster youth up to age 26. So those are largely not present in what we have currently in Georgia. The Pathways to Coverage program expires in September, and so we have submitted a waiver to extend our 1115 demonstration waiver for 5 additional years. And in that waiver, there are some tweaks being made. So I know we're going to talk a little bit about that in a minute, but all that to say, what it looks like now will likely look different, and at some point we will also have to align with H.R. 1. But for now, what we have is more restrictive than H.R. 1. There aren't any long-term exemptions. And though there is, technically, folks are reporting on a monthly basis, most of them, our state is not actually using any of that information to disenroll folks. So that is sort of where we're at the moment. We also, in our original application, we're going to be charging a subset of folks making 50 to 100% of the federal poverty level premiums. and they were never actually able to execute that. So that is something that is in our current program design, but not actually being implemented. So there are quite a few differences, but I think the biggest takeaway is that Pathways is a little bit more restrictive than HR1 is.
And I think to those last 2 points, the fact that premiums were never charged, the fact that, people meeting the qualifying activities were not reasons for them to be removed. I mean, those are the philosophical heart of this program, right?
Yeah.
And I think it speaks very much to how something might sound good in a press release or on paper or in the halls of a legislature, but then when you actually have to, make it work, that's a little bit different. I wanted, Deanna, to go to you because, it's really easy to think about these programs in kind of this high-level philosophical way, but ultimately this is about people getting health coverage to keep themselves healthy.
Right.
And so you've worked for the last few years to help people navigate the kind of enrollment process. So maybe and walk us through what that really looks like for people. What does a typical enrollment process look like from you kind of start to finish? And I think this gets to some of the administrative complexity.
Okay. So I am going to speak about the website prior to the updates they just recently made. When Pathways first rolled out, they started an application. It's the same platform for all medical assistants. So it wasn't a difference in what you were applying for. You couldn't say you want to apply for Pathways as you can now. So going through that application process, you still fill out the basic questions for medical assistants, but then you're given this option to ask if you're interested in Pathways. And you have to read the Pathways disclaimer as well as sign a Pathways consent form to even be considered for Pathways. But navigating through the gateway system was also one of the biggest issues. People going through that were always talking about having glitches, or they were getting kicked out, and then they weren't getting help when they called the customer service number. So the the caseworkers who are there to help you through your process, they weren't available or they couldn't get to them. So those were some of the issues with it. Also, one of the major issues my clients face is uploading documents. Trying to upload documents in the system and they're telling you, oh no, we don't take this type, we need a PDF or a JPEG. A client may not be familiar how to convert that document. So they'll have to send it over to me, I convert it and upload it in Gateway for them. But that's an extra step for you when you're trying to get coverage. Knowing that if you don't turn in all of your documents, that could lead for you being denied for coverage. So just navigating the Gateway portal has always been a hindrance for a lot of clients. For me, I am in the Central Georgia area, so I focus on a lot of rural communities. A lot of them do not have access to high-speed internet. So trying to upload a document using just your smartphone is already an issue because the digital access is not helpful for you. The previous website was definitely not accessible well on the smartphone. The new website is more accessible. But again, those were some of the issues a lot of clients face while trying to apply for this coverage.
And my understanding too, Deanna, is it's not just once they finally get all over these hurdles, it's not like their Medicaid card shows up the next day.
No. So being honest, I'm an enrollment assistant, so I help you with the application. So it's up to the caseworker and the defense office to determine eligibility to say that they're approved. But say you get that approval letter in the mail, yay, you're going to get Pathways, you'll have coverage. It still takes a time, I always say 30 minutes and sometimes longer before they actually get their cards in the mail to use their coverage. Yeah. So as an enrollment assistant, I have to take an extra step. I'll reach out to the Department of Community Health using their Medicaid number and the GAMIT system to verify which CMO they're in order for them to get that client ID number to use for coverage. So that's an additional step if you needed to make an appointment after you got your approval letter.
And you meant 30 days instead of 30 minutes?
Oh yeah,
Okay.
Never 30 minutes. Forgive me, y'all. Never 30 minutes. I don't
Leah,
think
do
nothing cooked that fast, but rice.
Yeah.
But no, I'm sorry. It would be 30 days or longer before they get that card in the mail.
And there are only so many Deannas in the world, right, who can help people do this work, especially if you consider that federal navigator funding is going to be slashed by 90% next year.
And I did want to piggyback on what Deanna's saying. So like the rollout of any program is only going to be as successful as the eligibility and enrollment infrastructure on which it's based. And what we knew here in Georgia already is that we've seen long-standing disinvestment in that infrastructure. So we have pretty low-paid DFACS workers, which then results in pretty high turnover rate. So that's part of the infrastructure. Then the other part of the infrastructure is our gateway system, which is that integrated eligibility system with both the consumer-facing side and then the back end. And we already knew that has had long-standing issues that kick people off their coverage for procedural reasons or make it hard for folks to enroll. So we were sort of building on what was already a weak system and layering on additional pressure. So Deanna talked about the initial enrollment process. We had someone reach out to us. We had interviewed her for some research, and she backed out to us because she said, hey, in my initial interview, I shared with you guys about my enrollment process. It was easy. It was no big deal. She was a former social worker who was in graduate school, so she had very high digital literacy. She was already familiar with the gateway system from her time as a social worker. She'd help clients enroll. She knew our whole documents were. So for her, enrollment was a breeze. However, at renewal, even all of these like sort of strengths she has in her toolbox to navigate this system, she still got in denial. She almost lost her coverage because of the weakness in the system. You know, she was calling to ask, well, why did I get denied? Every time she called, she got a different reason. She was having trouble with the call center. She said they'll only answer a call from the same number once per day. So if you have a question and they answer it and then you call back to say, hey, I did the thing that you told me to do, that's not possible. So I just wanted to emphasize that there's, it's not just about like gaining coverage, also maintaining coverage. This additional paperwork burden and then administrative barriers really are weighing a lot of people down, including people who meet the eligibility criteria.
Yeah, and at least in a state like Georgia, I mean, it's like if you are covering a state that has conservative leadership, they see no real need to invest in an eligibility system if they're not necessarily looking for more people to gain public assistance, right? And Leah actually put this great map together because I asked for updated numbers from the state and they did not get back to me. But I think this really speaks to not only how the program is actually functioning for people, but gets to kind of the heart of our conversation today about rural health. So Leah, talk a little bit about how enrollment has gone and how it has even fallen short of what the state expected.
Yeah, so just some background. So y'all know that Georgia has one of the highest uninsured rates in the country. We're like duking it out with Oklahoma and Oklahoma and Texas for the top spot. And that so the burden of our uninsured rates really fall heaviest in Georgia on our rural counties in particular, and also on our communities of color, particularly Hispanic community. And so all that to say, there was very high need here in Georgia. But what we saw after year one is there were like approximately 4,300 people that enrolled after year one. And you can see from that map that more than 40% of Georgia's counties still had fewer than 10 enrollees after the first year. So we were really not sort of meeting the need, nor did we meet any of the sort of enrollment sort of benchmarks that we set for ourselves as the state. And then fast forward to year two. So year two for us would be at the end of June of 2025. There were approximately 8,000 people enrolled. And our Department of Community Health tells us that there are approximately 240,000 Georgians earning less than 100% of the federal poverty level, 19 to 64. So that's the number we use for potentially eligible. It's based on age and income, so it's likely lower than that if because there's some people in there that don't have the right legal status to be eligible for Medicaid. But regardless, so generally 240,000 people potentially eligible for this program, and only 8,000 of them enrolled after second year of implementation. So you can really see how enrollment really is sort of falling short.
Yeah. And again, this is, to go back to that number from the first slide, despite 100,000 plus people applying, right? So people want this coverage. Something that I think about when I look at this map too, and Deanna, I'm wondering if you can speak to this. So, we call them casually work requirements, and whenever we do that, I think like someone in the governor's office, they're like, blood pressure raises by a little bit more because there are other qualifying activities, right? As with HR1. So you can volunteer, you can go to school. We've seen some pretty heavy enrollment in Georgia from students, right? Because like if you go to school, getting a transcript is probably going to be pretty easy if you're pretty digitally literate. But the thing that I've always kind of thought about too, and I think this map gets to it, Deanna, like what are the options for people who don't live in urban centers to do some of these other qualifying activities, or even find meaningful work that's easily documentable?
That's hard to say because the clients I work with, some of them do work through temporary agencies, or they do side gigs. They may be a mechanic or do some form of self-employment. But for those who try to do community service in the more rural counties where we don't have a big United Way or big organizations to volunteer at, that puts additional work on that director for that organization. I have counties that are small like Peach County, and it may be one nonprofit or two nonprofits there. Then their executive director has to complete a form or fill out a calendar for me to show the volunteer hours. I have to go back and forth with them to make sure that they have everything calculated correctly, they have the hours wrote down, because of course they don't want to write down false information, but that's additional work on them. And they're not doing it for themselves, they're doing it to help people who are volunteering for them. So if you don't have organizations who's willing to do that for you, that's a document that may be hard to receive, to upload, to verify that you've been, whether it's at your church, you've been volunteering or doing community hours at another nonprofit organization. If they're not willing to have that document available and they don't have it in a timely manner for you to upload, then you could be denied for coverage.
Mm-hmm. Yeah.
And Deanna, isn't it that there's no standard volunteer form to fill out, right? It's sort of like they kind of guess what is needed, and then it's caseworker by caseworker if they'll accept that documentation of volunteering?
Yes, that's how it would look when the client's looking at it. But again, since I help them, I'm like, okay, well, we need it to have a letterhead from that organization. It has to be signed off on the person who's signing off on your volunteer hours. I provide the information and education to let them know what is needed on that document. But if it's someone who's just completing it and they think they can do community service, they may just turn in, hey, I did community service at my church, and it's up to the caseworker to accept it or ask for additional information.
Mm-hmm. Yeah, and just the like amount of human time that it takes, I think, is really worth reflecting on here, because it's, again, these are systems, every state agency is facing staffing shortages. And technology can only take you so far when ultimately, like, AI can't verify whether, the document's legit. Maybe it can, I don't know. Dr. Oz thinks it can. True, he has said that. And so I think, too, that's something to really watch in your states as this rolls out. I mean, I think a great story to do is just follow someone through the enrollment process, right? Just like sit down with them at their computer and, shoot over their shoulder and show people, because I think it's really kind of abstract to say, oh, well, it's complicated to enroll, right? Like I spoke with a young man for a story recently. He was 20, he was tech savvy, and he called a regional office who could not connect him to his caseworker. He tried to escalate it to his supervisor, and the phone number they gave him was for a fax machine, right? All these little friction points are enough to get someone to throw up their hands and say, I'm done. Yeah. And again, not only has this program not enrolled many people, it's also cost a lot of money, and that's not just money for states, that's federal money too. So Leah, you want to talk a little bit about that?
Yes, my favorite thing to talk about. We have been sort of tracking. So the program was originally approved in October 2020, and as Sam mentioned, between October 2020 and July of 2023, there were some legal battles, but still the state began sort of the implementation process. So between January of 2021 and the end of June of 2025, which is the mark of our 2-year implementation, they have spent over $110 million combined federal and state funds And less than a third of that has gone to healthcare benefits to let people see the doctor, fill their prescriptions, et cetera. And in fact, as you can see there, about 50% of total funds has gone towards our eligibility and enrollment system known as Gateway. So I've heard a lot of people say, oh, it's the creating sort of the bureaucracy for a work requirement. That's just a startup cost. But in Georgia, that has not been the case for us. We have consistently, if you look at the CMS 64 forms, which is sort of like the invoice the state sends to the federal government to pull down their federal match for all things Medicaid, you can see that we have consistently spent on Gateway in almost every single reporting period since January of 2021, of the reporting periods in which we spent money on Pathways. Almost all of them have a charge for Gateway. And we continue, again, because we are extending through 2030 and we're making modifications, we will continue to be spending on Gateway. So I think that is sort of a misnomer to call sort of spending on the administrative side of things a startup cost. I also do want to also note that Georgia has used about $20 million in American Rescue Plan funds to roll out an awareness campaign, which is important. Obviously, it is really critical to invest in education and outreach. We didn't invest in it until the program had already started, so we were kind of on a late end of things, but it was a little muddy because the program launched in the bit of Medicaid unwinding. But regardless, you see there, that is a very large chunk of spending we have spent on an awareness campaign when you, again, compare it to healthcare benefits, and we haven't seen a large shift in enrollment in the time that awareness campaign has been running. So I think that's an important thing to note from our state is the way in which we structured that campaign. I think that there are some lessons learned there for other states that could maybe be implemented differently as well.
Yeah, and that campaign, as I recall, wasn't launched until a year after the program. But now there's ads on buses. Deanna, I think that since you're work with people on the ground, is that awareness campaign working? Do people know about Pathways?
Well, they know about it when I tell them. With our digital information, we try to make sure it's easy that they know what Pathways is and how to apply. Now, a lot of people, when I go into the community, it's like, what is Pathways? Or maybe I'll get a call, hey, I want to apply for that new Pathways. How do I enroll? And I'm like, hold on, let me give you the information. So for my community, I haven't seen a lot of people who've been aware of it based on their campaign. I told them, I said, I'm not sure how they may be marketing it, but a lot of clients in the rural area are not familiar. A lady who I've been working with for the past 4 years, she's like, I didn't know this exists. I said, I come out here with this paperwork every month to y'all. But a lot of people are not familiar with this, or it's not available in their area. You have to meet people where they are when you're giving them this information. So sometimes I don't know if they're doing a commercial, but most people don't use cable anymore. They're on live streams, so it may be difficult to reach certain clients. But I go out by outreach and education from my end, and I also use some of the state documents as they're updating everything constantly. But not too many people are familiar with the program still to this day.
Yeah. Go ahead.
I did want to mention one other thing. Sorry to backtrack just a little bit, but because this was such a big part of the discussion is how do we reduce federal spending on Medicaid? So I do just want to note for y'all that the blue is state spending, the orange is federal spending. So because you can draw down a 90% match, no matter what state you're in, you can draw down a 90% match on design, I forget what the words are, like basically upgrades to technology, certain upgrades to technology. The vast majority of our spending on Pathways has been federal spending. So the idea that somehow the federal government is going to save money by creating all this new bureaucracy is just not what our experience has been. It has actually been the federal government that has borne the majority of the costs for this program. So I did just want to note that too, as it relates to HR 1.
Yeah, I mean, so the savings come basically from coverage losses.
Yes, yeah.
Yeah. An important thing to note too, and this is one of the ways that Georgia's program is different, and this is something that the state will say. So to parrot the state for just a second, having heard these talking points many times, more people are on Medicaid in Georgia than were before this program launched. That is objectively true, right? There are 8,000, however many people with health coverage now. Compared to fully expanding Medicaid, it's a much different number. The thing that's different about Georgia's program too versus what we're going to see with H.R. 1 is Georgia's is a front door verification. H.R. 1 is going to apply to people currently on Medicaid, right? And so in Georgia, it's suppressed enrollment. It hasn't kicked people off. And this is why, some people do refer to it as a Medicaid expansion because it is. But just compared to full expansion, it's a very different thing. So that's just something to keep in mind. Leah, can you talk a little bit about some of these changes that you alluded to them earlier? But Georgia's waiver expires on the 30th of September. CMS is, unless CMS approves it. Georgia's made some pretty significant changes. So talk about what those changes are.
Yeah, and I do credit our state because they have. In our waiver extension application, they are making some changes to the program that are responsive to what we learned. And they've also made changes that are not represented in the application on sort of the back end to help streamline a little bit some of the sort of biggest kerfuffles in the gateway system. But so in the application itself, I think the biggest things are that as we talked about, so the original design called for monthly reporting, and the state was going to originally, basically reassess people's eligibility based on that monthly reporting. They were never actually able to make the modifications in the technology system to do the automated audits of that monthly reporting. So in the extension application, we are moving to verifying qualifying hours and activities at initial enrollment and yearly renewal, sort of like regular Medicaid. However, currently, they at no point announced to consumers, hey, you don't have to do monthly reporting anymore. So people still have that paperwork burden. So I think that's a pretty fairly cruel thing for people to still having to be doing, even though that it's a fairly meaningless process, just taking up a bunch of their time. The other thing is, like we talked about, they originally wanted to charge a premium for people earning 50 to 100% of the federal poverty level. That never got implemented, so that's coming out. And then they are adding some new qualifying activities, one of which is compliance with SNAP ABOD, and the other one, which is, I think, will have more potential for expanding coverage, is a new qualifying activity, not exemption, they're making it a qualifying activity, is being a parent or caregiver of a child under the age of 6. And then there's some other sort of modifications in there, but those are the big ticket items.
Yes.
What do you say?
Yeah. And just another point to make on this spending, because some of my colleagues at KFF Health News have done some great reporting on this. This money is not just going to some nameless, faceless. This money is going to consulting companies, right, to build these eligibility systems. And so, if we think about responsible use of taxpayer dollars, I think there's something to think about there. Okay, so we are going to watch, all of us, HR H.R. 1 roll out. So to maybe circle back to the big idea of this panel before we maybe get to some questions, Deanna, what do you think the kind of the big takeaway people should take away from Georgia's experience over the last 2 years, and really thinking about the people, right? Because this is ultimately who we're talking about people.
Okay. The biggest takeaway that I'm going to give y'all right now is y'all see the numbers. Numbers don't lie. So we see that obviously the system is not working for the people. But for us, the biggest thing is a lot of Georgians want coverage, and we're not talking about Georgians who are not doing anything. We have Georgians who are working who just can't meet those 80 hours of qualifying activities. So unfortunately, those Georgians are struggling or left without any other options because they don't meet the requirements or make enough income for Georgia Access, and because they can't meet 80 hours of a qualifying activity, even if it's employment, they can't qualify for pathways. The biggest thing is that all Georgians need access to health care and health insurance, especially our low-income Georgians. So they shouldn't have to go through all of these hoops and barriers with all of these systematic and administrative issues to get coverage. I would say the work requirements and qualifying activities are just an additional hurdle that they're going through, along with having a defects office that's not successful. We got to remember that all angles need to be examined. The system needs to be working for the people.
Yeah. Yeah, Leah, how about you?
Yeah, I agree with everything that Deanna said. And I would say, I mean, I think that, this is what we have. So how can states learn from Georgia's experience and Arkansas experience and implement this in a way that sort of mitigates some of the harm? So I would say, for example, one lesson learned from Georgia is we have not in any way leaned into automatic enrollment. So we have all of these, for example, women who are rolling off their postpartum Medicaid coverage. We already know how much money they're making. We know, are they working? We have the information on those women. So could we not just automatically enroll once their postpartum coverage ends? How can we leverage automatic enrollment to go ahead and get them enrolled in pathways so they don't have any gap in coverage, and just have them opt in, say, hey, you're eligible, we already did your paperwork, would you like to be a part of this program and continue your Medicaid? So we have largely not leaned into sort of that automatic enrollment that would take the burden not only off the consumer, but also off of these state agency workers. And then I think there's things to learn as well from, learn from the ways in which Georgia is amending its program. For example, as it relates to the premium requirements, as it relates to, monthly reporting to show that, obviously that's very challenging and would have been very expensive to implement. And then I think a big takeaway for me is our awareness campaign. I think that we are not designing these programs that keep people's real lives and their real needs in mind. So when we're thinking about people that are making $15,000 a year, as Deanna said, they are not watching cable. They are not listening to Sirius XM. They are struggling to afford rent. They are struggling to keep their cell phone turned on for the entire month. So an awareness campaign needs to actually meet people where they are and leverage trusted, hyperlocal messengers. So that awareness campaign is important, but we need to invest in ways that are actually going to be able to spread the word to this specific population that could benefit from this program and the Medicaid expansion population. So that would be, I think, another lesson learned from Georgia.
Yeah, and maybe just to move us towards wrapping up. So, we're going to hear a lot, and y'all are going to hear a lot in your states as they try to roll out these programs from officials defending them, right? Maybe not the state Medicaid director because they're the one who's going to have to figure it out. But Medicaid is a state-run program, right? So even if CMS comes down with some guidance on what states should do, the expectation is that states are going to have a good bit of leeway. So I guess, equip our reporters with, if you hear X talking point, what you should really think about that. Because I feel like there is a lot, I think KFF has done polling that says if you ask people if people should work for benefits, they'll say yeah. But then, those numbers really go down when you actually explain to them what that looks like. So yeah, we've already heard a lot of talking points around national work requirements. So how should we kind of smartly navigate those?
So one thing I would say is, different state agencies move differently. So maybe in Washington State, they're going to have a beautiful dashboard that's got real-time enrollment data and cost data. But in states like Georgia, that is not something that they are, they're not doing regular press releases. They're not providing a website where that data gets regularly updated. You have to go and actively pursue that data through open records requests and other sort of avenues. And so I think that when we lean too heavy on just asking for, when we go to the department and just have a conversation with them, we really need some data to back up what they have told us. So for example, if you ask them how much Pathways costs, it would be a different number because they start their cost estimate in January of 2022. That full year that we were charging the federal government for Pathways from January 2021 to January 22, it does not exist for them. And so I think it's really important to be requesting the CMS forms, especially if you live in states where that's maybe not being transparently offered, request the regular enrollment data so that you can sort of verify what's being said about the sort of impact of the program and how it's rolling out. I don't know if that's...
Yeah, no, I think that's great. And I mean, this is, as the reporter up here, I mean, that's very true. It's a lot of people in here have dealt with the state Medicaid agency, and it's not really easy to get them to respond to inquiries. And again, when it comes to the numbers, their numbers that they will tell you publicly don't necessarily align with what they're reporting to the feds because they omit the fact that they're doing a different time window, right? So it's like, it's really easy to, well, actually, it's sometimes quite difficult to get straight answers from people about what's really happening with these programs, but there are records that out there that exist. I want to leave time for some questions. So we've got, again, probably two of the foremost experts on a Medicaid work requirement program. I know a few things too. So if y'all have any questions about what we've seen in Georgia or what we are maybe expecting out of the requirements in HR 1, we're happy to take them.
This is one from the virtual audience. And Leah, I think you may have answered this, but maybe a little more detail. The question is, does caregiving qualify as a work requirement? Thinking of mothers who don't have coverage beyond pregnancy, postpartum, but stay home to care for their children. I think maybe she missed your...
Yeah, so currently under the current program design, we don't have any long-term exemptions for things like caregiving. Going forward, there will be a new qualifying activity if you are a parent or caregiver of a child under 6, but it's limited to that. So a bit different than HR 1.
Yeah, so what is it in HR 1 for caregiving?
Yeah, so I think it's for children, parents and caregivers of children 13 and under, and then also of a disabled relative. Is that right?
Yeah.
I think, yeah.
Yeah, room full of health reporters. Okay. Yeah.
Hi, Nora Farrell. I work for a foundation in North Carolina. And so I'm sitting here just looking at your numbers and I'm like astounded. Like somebody should be blowing this up. And maybe somebody is. And so that's my question. Obviously, we expanded Medicaid in North Carolina, have enrolled hundreds of thousands of people. Now it's all in jeopardy. But as we think about talking about the work requirement piece, this is not a success story. 8,000 people, $110 million. But we know that work requirements, they don't, when people hear work requirements, everybody's like, oh yeah, we should have work requirements. There's not a lot of messages around work requirements that test well of why we shouldn't have work requirements. So I'm wondering, in Georgia, has anybody successfully come out and been advocating and using this data and these numbers and these programs to show why this is not successful and what are the messages that work to say work requirements don't work?
Yeah, so I guess I wonder which audience, I will say, I also think that it's important, you're from North Carolina, we're from the South, success is in the eye of the beholder. This, for some people, I think, would say it's working as it's designed. I do think that there are policymakers in our state that do recognize that it is expensive, enrollment has been low, but I guess it depends on which audience you're talking about for messages.
Well, and maybe this is where it's very different in Georgia, but in North Carolina, the goal was to, when they finally agreed, okay, we get bipartisan support, we're going to expand Medicaid. Then the goal, bipartisan, was let's get as many people enrolled as absolutely possible. And maybe that's not the goal in Georgia, but I'm thinking about, so then in North Carolina, when we have to start talking about whatever these work requirements look like, whatever the administrative burden looks like, what messages help explain to the general public or to people who are kind of paying attention that people are working. People don't seem to respond to the more than 85% of the people on Medicaid are actually working, disabled, caregiving, right? So I'm just trying to think of messages that will help people understand that putting these work requirements on are actually hurting everybody.
Yeah, I mean, I guess for me too, and this gets a little bit to the distinction between Georgia's program and what happened in Arkansas. I mean, I think in some ways the Arkansas situation is a little bit more what we're likely going to see with HR 1, right? Because we're talking about currently enrolled people having to meet a new requirement. I mean, we're trying to get people to listen, right? I mean, I think that's like, you know, and it's in our newsroom, we have written a number of stories about this, right? And, you know, it's led to the GAO investigating the program and its costs, but is that going to result in any meaningful change? Maybe not, right? I mean, I think the thing I think about too with your question is it's like we really don't have a lot of clarity on the kind of help CMS is going to give states to do this and what these state eligibility systems are going to look like. My understanding is that's guidance that's forthcoming from CMS, and no one really knows when it's forthcoming. But the thing too, there was $200 million total in HR 1 for states to stand up these programs. Is that right?
I think so.
Yeah. Yeah. Okay. Yeah. So that's the thing to think about too, right? We're 2 years in. Georgia's spent over $100 million, and you've got $200 million for 40 states, and DC is split up.
Yeah.
Right.
I do think there's also that KFF polling too that shows like overall when you ask people about a Medicaid work requirement, they support it. But when you add additional nuance like, did you know it doesn't lead to long-term employment gains? Did you know it comes at a high state cost? People shift from majority support to majority oppose. But I too would be interested in like what messages are most compelling to just the average person about this.
That's helpful. Thank you.
Well, and just one, sorry, I think about this a lot because it's just like, how do we do our jobs effectively, right? How do we reach people? I mean, I think the thing that is like kind of slightly clever about what Georgia officials have done is this is a Medicaid expansion. And, you know, someone can try to, you know, say Georgia has not expanded Medicaid, but then there's that caveat as laid out by the ACA, and by that, you can't put that on a bumper sticker. People don't know that. And so I think there's a way in which this was kind of a savvy way to do something, right? Because the general public doesn't know enough about Medicaid to tell the distinction between a full expansion and what Georgia's done unless you sit down with them for a few minutes and explain it to them.
Absolutely.
Yeah.
Thank you.
Karen.
Thanks for this excellent panel. My name is Karen Landman. I'm a freelancer based in Atlanta. It is really striking, Sam, that you said something about how if you're not going to invest in the outcomes of a program, then you're really disincentivized as a state government to invest in the infrastructure supporting that program, which in this case is this eligibility and enrollment system, this gateway website, basically, which according to that chart, has actually been the biggest recipient of investment, as a chunk of this program by the state and the federal matching, or the federal government. So basically what we're saying is they've spent the most money that they spent on this program on the website, right? On the process for getting people enrolled, but it doesn't work, and they really kind of don't want it to work. And I personally have experienced this as a person with a family member who is being disserved by the Medicaid system. Just trying to use the Gateway website is you just kind of want to drive off a bridge after a couple days of fighting with it. So I guess my question is, who are the contractors that are doing, who is doing this? Who is kind of maybe deliberately, maybe just by direction, dragging their feet as they build and maintain this garbage website?
You want to take that, Leah? Or I can, yeah, okay.
And AI isn't going to fix this, right? Because they fixed everything else.
I mean, at least in Georgia, it's Deloitte. I mean, Deloitte is Medicaid in many states, and I have colleagues at KFF Health News last year who put out some great reporting about this. You know, these systems are complicated to run, and if someone comes to you with an off-the-shelf package, it's like, hey, we can run your state Medicaid program. For a state lawmaker, especially in a state like Georgia, where we're only in for a few months of the year, sure, approve it in the budget. And the reporting from our colleagues has found that there's, if a company can charge a state every time something breaks, do you have an incentive to make a system that works, I think is a question.
I'm sorry to dominate here. Do we know who are sort of the biggest government players? As there's usually a revolving door between government and whatever contractor is effing up a system that serves the state. And I'm wondering if any of you know, are willing to name names on who the participants in that revolving door in this state are.
Oh, ooh. I actually do not know, and I think even if I did, I don't know if I'd tell a room of other reporters. But yeah, I mean, I would say go check out Rashna Pradhan, Samantha Liss are the two reporters who did a really great series of stories last year about Deloitte. So I would say start there, yeah, because at least in Georgia, the big player is Deloitte.
Thank you.
Yeah.
And they do a lot of campaign.
Yep. Yeah.
Thank you.
Hello. Good to see y'all. So I've got a couple, as someone who has covered Pathway since before its inception, I've got a couple kind of comments. One is, so you've got the money here from 21 on. Since the very beginning of Governor Kemp taking office, this has been his project. And I sat in the room with Deloitte contractors lining the walls with numbers that they had produced, presumably being paid by the government, since for all those years. So this is even missing that money from before that.
That's true. Yeah.
And so, and we don't have that, right? There's no way to, no one's like counted that up right now.
Yeah.
Yeah. For the studies that Deloitte did, okay, and that's Margaret Coker, who did a fabulous story on this. Second comment is, I want to say, as somebody who's been dealing with the governor's staff and in those meetings all those years, I can't speak to what's in their heads, and I don't have ESP. It has been my take in recent years that they want this to succeed now. They want a success. They would love. They took us into a meeting before this launched and gave us increased projections on how much enrollment they thought this was going to drive. You don't do that if you think it's going to tank. And in fact, it just, they told us 100,000. And so my question is, and this has been a question I think we may have discussed before, but I'll ask it again. If they really wanted to go all out and make it work and make it easy for people, and I'm thinking like, where do people first figure out I need insurance and I don't have it and maybe you can help me? It's the doctor when they go to the doctor. If you wanted to like have portals into doctors' offices and providers where people could sign up for Pathways, then if you wanted to have it work as seamlessly as PayPal, and you wanted to have it staffed so that the DFACS offices aren't actually empty because all of the assistants are working from home remotely, what would it cost?
You want like one number?
I don't know. Somebody told me $500 million. I don't know.
Yeah.
Are you saying what would it cost, assuming it's the same design?
No,
Like with a work
design, wait, if you're talking about who gets to enroll, yes. Same goals. We're going to help people have a healthier life by working, but a functional system where they think 100,000 people are going to enroll and 100,000 people actually have an easy path to enrolling.
It's like
this
like
is
a fun
probably-
thought experiment.
This is probably a computer engineering consultant question, but.
Well, I mean, I guess I would push back a little bit and say that it would be very challenging for us to get to 100,000 as currently designed, because what we know is that most of these people that are eligible for the program are likely already able to meet the qualifying hours and activities, but it is a paperwork burden that they're unable to meet.
If you eliminate the paperwork burden, if you make it completely easy. I think you probably don't have the answer, but
the work requirement itself is a paperwork burden, right?
Yes, it is.
Right.
If it were somehow paperless, I don't know. So.
Well, and this is something to watch. And I mean, Dr. Oz has said AI will help with this, right? And testimony before Congress. And so I think that there's a real question of like, what kind of tech is deployable to make a system like this work at a national level?
Well, I mean, I think this is, again, for example, where like what we saw in North Carolina, where when they fully expanded, they leveraged automatic enrollment, and they saw a huge surge in enrollment. So there are things we could be doing, but I'm not sure that I still think the premise of a work requirement itself is always going to create a paperwork burden. At some point as a human, you're going to have to go in and put in some information, and so I don't think you can eliminate that burden altogether if you have the work requirement in place.
I think we're kind of probably saying the same thing. Like, if you wanted to make it paperless, you would have to have some system built between employers or whoever where that information flowed seamlessly, and the cost would be astronomical. It'd be like a TVA.
Yeah, I mean, for example, with ex parte renewal, they have some of those systems in place, right? You can like pull down Equifax data, right? They do have a linkage with the University System of Georgia to make it easier for the college kids to, do that sort of like automatic re-enrollment. So some of those systems are there and are more robust in other states, but yeah, that's not a $0 cost either. So
We have time for one more question.
Can I make a statement regarding that? Because I'm an enrollment assistant, I also help people with Georgia Access and that marketplace application.
And that's the state's ACA marketplace, the state-based exchange.
Yes. Okay, so when they complete one of those applications, if their income is too low, Georgia Access is supposed to send it over to our state Medicaid office to process them for that. When they send those applications over, it doesn't consider them for pathways because that's an extra step when you do that pathways application. So that's why the automatic system, you would think if someone got denied for Georgia Access, if we had it set up where they could expand it Medicaid, they will automatically be given Medicaid here in Georgia, but that system's not set up like that. So even for those who are denied or don't make enough income for Georgia Access, they have to complete a new application to be considered for pathways. It doesn't automatically send over everything because of that qualifying activity piece that has to be completed.
Yeah.
Hey guys.
Hi.
Deanna, you mentioned that you were speaking about like a previous version of Gateway earlier. Kind of just, I guess the question is, like, with all this money we've put towards Gateway, have we seen any improvements? Have they made it any easier? Have we seen anything streamlined? And what were these changes that maybe you were referring to?
Okay, so the old website was more like a dinosaur, so it was hard to utilize on your cell phone. Everybody does everything on their smartphone, so if you needed to do the application, it was really hard to do the application on the old website on your smartphone because of how it looked. But they have made updates to the website, and one of their biggest updates that they're happy about is that it has an option for you to apply for pathways. So it does still give you the option to create an account, log in, or manage your account, but they created a separate option just for you to apply for pathways. So I have heard good things from the new website, which just came out, so it hasn't been out that long.
And they did recently, like, they reduced the number of screens. So they got rid of that separate pathways contract you have to sign. Now it's just the one Medicaid contract. And now it's like more of like an opt-in than an opt-out situation because they take you all the way through the, supposedly. So that there are they have made some improvements for sure. They have been responsive to feedback.
Right.
How were people applying before the change to Pathways?
When they did that, beforehand, when you do application, you had to just do the medical assistance application, which is for all classes of assistance under Medicaid. They just had to go through that application. And then you would have to be given the screen to ask, are you interested in applying? Are you interested in pathways? You had to select yes. If you select no, then it will just go on to the end of your application without asking for the qualifying activities. But if you are interested, you'll go to your next next screen for pathways, give you the disclaimer and the consent form, which you have to sign. And they are making the changes about the tobacco surcharge, correct? Yeah, they did ask the question if you use tobacco, and then the next screen would ask you to put in that qualifying activity.
Yeah.
You're welcome.
Yeah, thank y'all.